So hi guys, today we are here to talk to you about the skin cancer type 1 and what we're going to talk about is melanoma. Okay, so what about this particular melanoma? The introduction to the melanoma, let's kind of talk about that. So melanoma is basically arising from the malignant tumors, that is the melanocytes. Okay, it is a malignant tumor which is arising from the cells which is called as the melanocytes, okay, which are the pigment producing cells of the body. That's fine. Okay, now it is the most aggressive form of the skin cancer. This melanoma is the most aggressive form of the skin cancer, and it kind of accounts for less than 2% of all the skin cancers. Okay, it accounts for less than 2% of all the skin cancer. So even though it is the most aggressive form, it is not the most common one. It is basically only like it is less than 2% of all the skin cancers. That is what you need to understand. Now, however, melanoma is the one which is responsible for most cancer related deaths, because squamous cell and basal cell, they usually don't kind of kill the patients, but yeah, melanoma is something which is associated with the cancer related deaths. Now, early detection and proper treatment is significantly improves the prognosis of this particular patient. That's obviously fine, right? Now, let's cover a bit of a historical kind of background for this. So what you need to understand is that was probably first described by the Hippocrates in the ancient Greek. The probability that he described it first, but the first surgical excision of this, or the first modern surgical excision, was performed by John Hunter, 1787. Okay, then we have a Laennec, who in 1804, what he did was he identified the metastatic melanoma and called it as a cancer noir. Okay, so what is this cancer noir? It is basically a metastatic melanoma. Okay, now over decades, the melanoma research has increased a lot, and nowadays we basically have like molecular biology and immunotherapy and the targeted therapies for the management of these particular patients. We'll talk about that. Okay, now let's talk about the epidemiology. So it's around 5th most common cancer in the men, and it is 6th most common man's cancer in the women. But obviously this is the statistics of the Western world, like the USA, right? Because these particular patients have fair skin and they are more likely to develop the malignant melanoma. Okay, now incidence basically steadily increases worldwide over the last 4 decades. In last 30-40 years, we have seen that there is a rise in the detection of this malignant melanoma. Okay, now the highest incidence rate is basically seen in your Australia, New Zealand, North America, Northern Europe, all those particular things, for the obvious reasons, because their skin doesn't have a lot of melanocytes. Okay, now cancers, why there is an increasing trend for this particular melanoma? The reason is, one is probably because of the lifestyle changes, because nowadays like this UV exposure has become a big thing. Okay, the increased UV exposure because of lifestyle changes, and the same time now the people are more aware of things. Okay, so what they do is there's an early detection. Okay, there's an early detection, and we do the surveillance in a better manner. So early detection and improved surveillance, this has again led to the increase in the incidence of the malignant melanoma. Okay, now pigment is basically actually protective, and that is why this is more common in the fair skin individuals. Okay, so predominantly a disease of the whites, and higher kind of rates in the fair skin individuals, blonde, red hairs, blue eyes, all those particular things, we have an increased risk. Then there is one particular what you call as skin type, which is called as a Fitzpatrick skin type 1 and 2. These are the ones which is having the highest risk of this. Now, what is this Fitzpatrick skin type 1 and 2? We will talk about that. But these are the ones which have a highest risk of the malignant melanoma. Now, when we talk about the age distribution, it is basically occurring in middle-aged adults, 40 to 50 years. Yeah, that is what is a middle-aged kind of individual where we kind of get this. Below 45 years, it is quite less. Like 1 in 6 cases only occur in the people who are less than 45 years of age. Okay. Now, let's talk about the risk factors. So, what are in general the risk factors for the malignant melanoma? Okay, so familial history. So I said that, yeah, the familial history, like if you tell somebody in your family has suffered from the malignant melanoma, the risk is around 5 to 10%. Okay, 5 to 10% of the cases have that particular stuff. Then we have Fitzpatrick type 1 and 2. I just described that. So what is this Fitzpatrick type 1 and 2? So these are the people with the light skin and high sun sensitivity. So if at all there is a patient who is having light skin and the patient is basically having high sun sensitivity, these are described as Fitzpatrick type 1 and 2, and these are the ones which are more associated with what you call as a malignant melanoma. Then Xeroderma pigmentosa. What is this Xeroderma pigmentosa? Xeroderma pigmentosa is basically a condition where there is a defect in the DNA repair. Okay, so there is a defect in the DNA repair, and because of this, these particular individuals are at higher risk for development of a malignant melanoma, because in our body also what happens is multiple mutations are basically taking place. but our body basically takes care that that particular DNA is getting repaired from time to time manner. But if at all there's a defect in the DNA repair, then yes, there will be a risk for the development of a malignant melanoma. Then we have a dysplastic nevi syndrome, which is BK mole syndrome, more than 100 atypical nevi. This is again a risk factor for that. So these are the genetic risk factors. Then we have environmental risk factors. What is included in this? So you have UV radiation exposure. So what you need to understand is that intermittent exposure is a more important risk. What do you understand by intermittent exposure? That yeah, like you have got a severe exposure to the sunlight for some time, and then for a couple of days you did not have an exposure. So that is what is called as an intermittent exposure. So intermittent intense sun exposure has the strongest risk factor for the development of this malignant melanoma. Are you understand my point? Chronic sun exposure is not linked to the malignant melanoma. Chronic sun exposure has been linked to the non-melanoma skin cancer, like the squamous cell cancer or the basal cell cancer or something like that. Okay, please understand this. Then there are tanning beds. What are these particular tanning beds? So you have UVA. So ultraviolet A, that is 320 to 400. Nowadays some people like to get tanned, and what they do is they basically expose themselves to these UVA kind of light, that is 320 to 400 kind of nanometers and everything. So these tanning beds are associated with an increased risk of your malignant melanoma. Okay, now this has proven epidemiological links with the melanoma. That is what you need to understand. Now severe blistering and sunburns in the childhood and adolescence. So if at all there is a severe blistering or the sunburn in the childhood and adolescence, that is again associated with an increased melanoma risk. Okay, just remember that it's an important thing. Okay, now upper socioeconomic status is the one which is more associated with this malignant melanoma, and immunosuppression. So you would have heard, or you would have kind of known, that in the patients who receive the organ transplant, what happens in them is that there is an increased risk of skin malignancies. Okay, now obviously squamous cell carcinoma is the one which is the most common type, but still it also increases the risk for malignant melanoma as well. So organ transplant recipients and HIV patients who are suppressed, they have an increased risk for development of a malignant melanoma. Now let us talk about the precursor lesions. So what are the precursor lesions? So melanoma arises de novo in the normal skin in around 60% of the cases. De novo, even if there is no mole or anything, the patients can have the de novo origin of the malignant melanoma. That is something which you need to understand. Now 40% arise from the pre-existing lesions. So what are these pre-existing lesions? It can be either a dysplastic nevi. What is this dysplastic nevi? This is an irregular pigmentation or indistinct margin. Okay, so if at all there is a mole with an irregular kind of pigmentation or an indistinct margin, this is what is a dysplastic nevi. Then there can be a congenital nevi, that is a giant congenital nevi more than 2 centimeters, carry a higher risk. So if at all there is a like a nevi which more than 2 centimeters in size, that again has a increased risk of development of this malignant melanoma. Spitz nevi, so pink or the brown kind of a benign lesion, but atypical ones more kind of progress. Okay, so these are the precursor lesions for development of a malignant melanoma. At least remember the names: dysplastic nevi, congenital nevi more than 2 centimeters in size, any particular nevi, and Spitz nevi. So these are the increased risk for development of a malignant melanoma. Then pathogenesis and molecular biology. Okay, now here what you need to understand, there are a lot of genetic mutations which are associated with this. Now melanoma has the highest mutation burden of any cancer. So the Cancer Genome Atlas Network in 2015 identified 4 genomic subtypes. Okay, so what is the most common one? It is the BRAF gene mutation. So this BRAF gene, remember we talked about that, it is also associated with the papillary thyroid cancer, right? So the same BRAF gene mutation can also lead to the development of a what you call as malignant melanoma. Okay, so this is the one which is most commonly associated. BRAF gene mutation 50% most common. Then we have a RAS mutation, then NF1 neurofibromatosis 1, then triple wild, that is 5%, lacks major kind of mutation. So in around 5% of the malignant melanoma cases, we do not have like significant mutations, but yeah, like in most of the cases we have BRAF or the RAS or the NF1 gene mutation. These things are kind of present. Okay, then the key pathways involved. So there are various kind of mutation pathways which are associated with this. So MAPK pathway, which is associated with the BRAF, RAS and the NF1 gene mutation, it is responsible for the uncontrolled cell growth. Then there is PI3K AKT pathway. This kind of drives the drug resistance to the BRAF inhibitors. Okay, so whenever we have any particular gene mutation, we can